Joining us. Hi, we're going to get started in just 1 minute. Okay, why don't we get started with introductions? Um, we're thrilled that you're joining us today. I'm going to just introduce myself first, and then we'll turn to our incredible speaker. My name is Jessica Levin, and I am the Chief Program Officer of Let's Talk Menopause. And Let's Talk Menopause is a national nonprofit changing the conversation about menopause so women get the information they need and the healthcare they deserve. Our menopause talks are central to our education effort. And on our website at www.letstalkmenopause.org, we have our prior 20 menopause talks. They are a goldmine of information. All our talks are intended for information only. And so please seek medical advice from your doctor or another healthcare practitioner. And just a few housekeeping items. We have disabled the chat. So if you have questions, please put them in the Q&As, and we have reserved time at the end of the talk to answer some questions. We have a very brief survey at the end, so please stay on. It's 3 short questions because we want to continually adapt our menopause talks to make them as helpful as possible for you. And today our topic is Don't Go Breaking My Heart, Menopause, Heart Health, and You. And I wanted to introduce our incredible speaker, Dr. Erin Michos. She is an internationally known expert in preventative cardiology and women's health. She is an associate professor in the Division of Cardiology at the Johns Hopkins School of Medicine, and she's also the director of Women's Cardiovascular Health Research and the associate director of preventative cardiology at Johns Hopkins University. She has also authored over 650 publications, 11 book chapters on women's cardiovascular health, including lipid management, cardiometabolic disease, coronary artery, calcium, inflammation, and biomarkers of risk. And she also spends a lot of time mentoring and has received 2 mentoring awards. So we just wanted to thank you so much for taking the time to be with us. We know this is an incredibly important topic, and that women our age do not think enough about this topic and know enough about it. So today we're going to focus on the risk factors for cardiovascular disease that we can modify, and how to screen for them, treat them, and prevent them. And I wanted to start, Dr. Michos, if the audience was going to take away a few lessons from our talk, what would they be?
Well, great. Well, thank you again for having me on your program. And yes, this is such an important topic because unfortunately, cardiovascular disease is still the leading cause of death in women. And although most women fear breast cancer, which is, a terrible disease, my mother had breast cancer, women are more likely to die from cardiovascular disease. But we think about 80 to 90% of it is preventable, which is why this is so important of a topic. But it's important to emphasize that why cardiovascular disease is more common in older ages, that it can affect women at all age groups. And in fact, the fastest growing rate of heart disease is in middle-aged women. So heart attacks in younger women is on the rise, and it's actually the fastest growing rate is in middle-aged women, this age range that we're talking about. And often this is a age range where women are so focused on, they often have dependent children at home or aging parents, or they have their spouses or partners, their careers. They're focused on taking care of everybody else in their life, but it's really important that they know their own heart disease risk. And so to emphasize that, women are at risk even at younger ages. And then what we'll talk about, their second point, is the importance of knowing their own specific risk factors so that a tailored plan can be created for them. And it may be that traditional risk factors that they might have heard about, but today we'll talk about some female specific risk factors that are unique to women that they may not be aware of, as well as some emerging risk factors, including a certain type of cholesterol called lipoprotein little a, and also the role of inflammation. So hopefully with that, they can be armed with information to talk to their doctors about having a tailored prevention plan that's right for them.
That's great. I think this topic, it comes as a surprise to a lot of us when a doctor first may mention something, and a lot of doctors don't mention anything. I wanted you to talk a little about why after menopause does the risk seem to increase dramatically?
Right. So rates of cardiovascular disease do go up after menopause. But again, I want to keep emphasizing that we do see heart attacks in younger women of reproductive age. So this is why we need to think about a life course approach and think about prevention from early age.
Yep.
But there are some changes in cardiometabolic health that happen around the menopause transition with the loss of estradiol. So unlike in men who have sort of a gradual loss of testosterone over decades, about a 1% to 2% per year, women have this abrupt cessation of estradiol after the final menstrual period. And so we do see a change in lipids and cholesterol. So cholesterol does go up after menopause. So that can be someone who has a genetic susceptibility to high cholesterol, can be exacerbated at the menopause transition. Some women have an elevated blood pressure after menopause. We see this unfortunate change in body composition that even if one's weight on a scale doesn't change, there's a shift in body fat with more adipose deposited in the abdomen, the visceral cavity, which is a more risky place to have fat tissue, because that can lead to increased resistance to insulin and predispose to prediabetes or diabetes. So there's these unfortunate metabolic changes that occur. So if someone hasn't had a heart checkup before then, and again, I encourage starting that like decades earlier, but menopause is a good time to get a heart checkup because of these changes that occur in some of the cardiometabolic risk factors.
So I'm going to ask you to define terms as we go along, but the two most important terms I just want you to define now for everyone is, one is just the meaning of cardiovascular disease and how that differs from heart disease.
Right. So cardiovascular disease is the larger umbrella term that includes the heart and the vascular system. So that includes, the brain. So stroke and TIAs are a type of cardiovascular disease. And actually,
you define what the TIA is.
A transient ischemic attack, like a mini stroke.
Okay.
Cerebral vascular disease in the brain and the brain's arteries is a type of cardiovascular disease, heart disease, and then disease in the other blood vessels, the vessels to the periphery, like the legs. We call this, peripheral arterial disease. So it's really disease anywhere from the heart and its major blood vessels, which are throughout the whole body. Now, so heart disease is a subset of that, and it's specific just to problems of the heart. And then within cardiovascular disease or heart disease, there is atherosclerotic cardiovascular disease. So atherosclerosis is this process where plaque is building up in the heart arteries, and we'll talk about risk factors for this. But elevated cholesterol is a major driver, but other things like inflammation and smoking and genetics, and there's other risk factors that can lead to this process. So things that are due to atherosclerosis or plaque, that's atherosclerotic cardiovascular disease. And we treat that a little differently because we're really focusing on preventing plaque progression or shrinking plaque. And so lipid management is a core focus. But there can be other types of heart disease, like rhythm problems, like atrial fibrillation, or valve problems from valve stenosis or valve leaking, regurgitation. There can be heart failure, which can be due to other causes that are not atherosclerosis. So that's also a big umbrella. And that's why it's important that younger women know that they could still be at risk for a heart attack, even if they don't have traditional risk factors, because there's a rare type of heart attack that occurs sometimes predominantly in younger women, called spontaneous coronary artery dissection, SCAD, which is a type of heart attack due to an artery tear as opposed to atherosclerosis. So it's important to know that there's more to heart disease than just atherosclerosis, but that's the major category that that we focus on, because that's the predominant type of cardiovascular disease is due to atherosclerosis.
That's very helpful, because I know these terms are just, they can be overwhelming, and that's one of the reasons I think we just shut down on this topic because of those terms. I'm wondering if, given we're going to turn to modifiable risk factors, can you just explain what a modifiable risk factor means?
Right. And so modifiable risk factors are risk factors that we can either prevent from developing in the first place, or if it's present, to be able to treat. And so we can modify that number, improve that number, and treat that. And so that's really our focus for screening and treating things that are modifiable, things that we can change. Unfortunately, there's some things we can't change. We still haven't figured how to turn back the clock, so we can't change age. So age is still a risk factor, because these events are more common in older adults. We can't, change the biological sex that we were born at birth, male or female. We can't change our genes. So, we're born with a genetic makeup, and family history is an important risk factor. But really, it's what we're going to talk about today is that genes are not destiny. And one might be at higher risk because of their genetic, risk factors, their genetic makeup. But there are things we can do to, prevent the consequences of this genetic risk, such as earlier and more intensive preventive therapies, healthy lifestyle, being more aggressive about treatment. So again, we think about 80 to 90% of cardiovascular disease is modifiable, is preventable, is treatable. But in order to treat, we have to identify risk in the first place and make sure that we treat that risk. And we see, compared to men, that women are more likely not to be treated, to not have their cholesterol treated, to not be on statins, even though they have elevated risk. And so women are consistently undertreated, which is a complicated issue. But some of it has to do with that women, and sometimes even their doctors, perceive them to be at lower risk than they really are.
Yeah. One of the things before we go into lipids and other risk factors is I wanted you to talk a little bit about lifestyle, because a lot of times when women are told, you're at risk, our first reaction is, if we can, to try to change our lifestyles, like better eating, better exercise, whatever that entails. Tell me a little more about how that fits into this puzzle.
Yeah, a healthy lifestyle is the foundation for all prevention efforts. And really, it should begin in utero, So it's important to start early in life and really, focusing in our youth and our adolescence and young adulthood with following a healthy lifestyle that includes regular physical activity and following a heart-healthy diet, of which there are several healthy dietary patterns, but they generally are diets that are rich in fruits and vegetables, whole grains, beans, legumes, lean protein, fish, reducing saturated fats, but having more of the healthier fats, minimizing, processed foods as much as possible, minimizing highly refined carbs, sugar sweetened beverages. So these are sort of the foundations that, help keep the heart and its vessels as healthy as possible. Now, some patients, unfortunately, they're start later in life, or they have high genetic risk and they already have disease, they already have plaque in their arteries, they are already even maybe even had an event. And so while we still recommend lifestyle, sometimes if someone's already more advanced in this process, they need medications and lifestyle. So it's often not either or, it's both. So lifestyle probably has the most impact starting early, in youth, but sometimes by the time they get to midlife, we may need to do medications. And keep in mind, there's certain genetic conditions, like a condition called familial hypercholesterolemia, FH. This is in 1 in 250 people. So it's pretty common, 200 people, one have them, who have severely elevated cholesterol from birth due to a genetic problem. And diet just not enough. It can't, because of this genetic abnormality, they just have really high cholesterol. And so they need treatment, as early as possible. So if someone needs treatment, it's not necessarily a personal failing on their fault. If they can't get their cholesterol down with diet alone, a large proportion of cholesterol numbers is genetically determined. And so I have a lot of patients who follow a vegan diet and they exercise every day and they do everything right and they're frustrated, their cholesterol is still high, and that's likely due to genetics. But it may still need to be treated, and treatment works best in combination with a healthy diet.
So I know you're one of the country, if not the world, experts in lipids and lipids in women, cholesterol in women, which, as you've said, is there's not enough attention to this issue, and I'm wondering if, sometimes people use cholesterol and lipids interchangeably. They're not quite the same thing, but can you clarify what they are and what the difference is between them?
Sure. And I want to emphasize why this is always comes up as one of the core topics is that when you look at risk of a heart attack, about 50% of attributable risk is due to lipids. So it's like a major risk. It's not the only risk, but it's a major risk for heart disease. And this is why all of our preventive guidelines really focus on, a lot of cholesterol and getting cholesterol as low as possible. So lipids includes, both cholesterol and triglycerides, which is a type of blood fat. And cholesterol and lipid is carried in the body in lipoproteins, these particles, because cholesterol, fat can't dissolve in water. So it's carried in the body in these lipoproteins. That sounds just like it is. Lipo, it means it contains lipids, and it also contains some proteins. And they're made up of cholesterol and triglyceride in these proteins. And these proteins are different sizes. Now, the lipoproteins that we call sort of the bad cholesterol, the cholesterol that is riskier, these type of particles that can enter the artery wall and lead to plaque buildup in the arteries. This is sort of the precursor to atherosclerosis, is this lipoproteins get into the artery wall and they form plaque. And this is what happens in a heart attack, is that plaque is formed and it gets inflamed and it can rupture. And that's what causes a heart attack and stroke. So our big prevention, trying to prevent those events, is trying to prevent this plaque from forming or help that plaque shrink. So the particles that get into the wall all carry a protein called ApoB. So when we talk about the riskier particles, these are all the ApoB lipoproteins. Now, 90% of ApoB lipoproteins is LDL particles. And so that's why all of our really guidelines really focus on measuring LDL cholesterol, which is the concentration of LDL across all these particles. And that's really our primary target. There are some other ApoB particles. We'll talk about lipoprotein little a, which is a very genetically determined lipoprotein that's associated with early onset heart disease. So we're moving to recommending everybody have that one checked at least once. And then there's triglyceride-rich lipoproteins. So these are lipoproteins that are larger, that have a little bit more triglyceride in them. Those are VLDL, IDL. So likely triglycerides themselves are not harmful. We've tried lowering triglycerides, and that strategy alone doesn't prevent heart disease. But likely why triglycerides are risky is because they're a marker for these cholesterol particles. These triglyceride-rich lipoproteins have also, they're larger particles, so have more cholesterol in them. So it's really important to understand the burden of these more riskier particles, of which our primary focus is on LDL. For those who their doctors or they don't measure ApoB, that's not measured that commonly. One easy test, which is you can do a non-HDL assessment, which really is a good surrogate for ApoB. So what that is if you take a standard lipid panel and you take the total cholesterol number minus the HDL number, everything that's left is non-HDL. And so that's the second target after we try to get the LDL as low as possible.
Okay, so I'm assuming a lot of people in our audience that was very that may be over their heads. So what I just want to kind of make clear from what you said to our audience, LDL is still a significant,
the primary target,
which people have traditionally been tested for, and that's
part of a standard total lipid panel. That's one of the measures, and that's the one we really focus on, is the LDL.
Okay, I'm going to mention two other things because, as you said, there is some research showing that they are equally, if not more, instructive for women and their risks. And I don't think even people need to know right now exactly what they are, but one is called ApoB, APO-B, because the LDL is a part of that, but not the entire thing. And the other thing you talked about was LPL, which is another kind of particle, and so a lot of panels will show a number of different measures, but a lot of doctors are not offering that to their patients. We're going to go back to that in a second. One thing, I wanted to, there's been a concept in the past about good cholesterol and bad cholesterol. And people used to say LDL was bad cholesterol and that HDL was good cholesterol. And doctors do not think that's true anymore. So because tell them what you told me about a lot of doctors previously thought if you had high HDL, it protected you from if you had high LDL. So can you talk a little more about that?
Right. So I still consider LDL sort of bad. There's overwhelming evidence from genetic studies, observational studies, interventional studies that LDL is directly related to atherosclerotic cardiovascular risk in a proportional fashion, so that the lower we can lower it, the lower we can lower risk. So I still focus on getting the LDL as low as possible and thinking that still as the bad particles, like ApoB particles, of which LDL makes up most of them. Now, HDL is complicated. HDL, the particle itself, its function in the body was to circulate and kind of remove plaque from the arteries and bring it back to the liver, remove cholesterol from the arteries and bring it back to the liver. And that's the function of the particle. But unfortunately, when we measure the blood test, the HDL concentration in the blood, that is not a surrogate marker, a good marker of the actual function of the particle. And actually, there's, genetic studies have not shown HDL to be related to cardiovascular risk, just, not like, LDL, we have genetic studies, but not with HDL showing a relationship. And anything, we see kind of a U-shaped relationship where both low levels and high levels are associated with increased risk. And likely, when some people have really high blood levels, it doesn't mean that the particles are working. They may be big, fluffy, dysfunctional particles that are not effective at clearing cholesterol to circulation. So, a high HDL level should never, ever be a reason not to treat someone who would otherwise need treatment because they have a high LDL or ApoB or other cardiovascular risk factors. It doesn't negate the risk from a high LDL. A high HDL by itself, if the LDL is low, it's probably not risky in and of itself, but it should never be a reason not to treat high LDL. And too often I see women who come to me too late as a cardiologist, and they had high cholesterol for years, including high LDL, and they were never treated because they were told, oh, well, but you got really good levels of that good cholesterol. And then they end up having terrible coronary atherosclerosis. So really, I would focus on LDL and ApoB mediated risk. And as I mentioned, since ApoB is not measured very commonly, there, one surrogate that can be used as a sort of almost a substitute for ApoB, which you can get from just a standard lipid panel, as your non-HDL, which again is a simple equation. The total cholesterol minus HDL leaves all those bad particles left. And so that's your non-HDL, and that's our secondary target. But HDL is never a target of therapy. We spent years actually doing trials of drugs like niacin and CETP inhibitors. We tried to see if we could raise the blood levels of HDL, and it was all a failure. Raising the blood levels of HDL did not prevent heart attacks, did not prevent strokes. So we no longer are targeting HDL. But we've shown over and over again from statin trials and trials of non-statins that if you can lower LDL, you can lower the risk of heart attacks and strokes. And so I would really focus on LDL related risk.
And how do you decide when let's say you see a high LDL? What is, I'm sure it's a combination of things that makes you decide when to treat someone. What do you look for?
Yeah, so this is where we assess risk and make some decisions. So certain values that are very high, severely high, like an LDL above 190 is often enriched with individuals who have that genetic condition, familial hypercholesterolemia. And again, I'm talking about LDL, not total cholesterol, above 190. So the guidelines recommend treating that, from a young age, because left untreated, 30% of women who have FH with cholesterol that high will have a heart attack before age 60. So that's important to really treat. A healthier LDL is generally less than 100. And then there's individuals who are sort of mildly to moderately elevated. And this is where it gets a little bit more complicated, where we look at their other risk factors. But I do sometimes think we wait too long to treat because we want to think kind of like years of exposure. So these are particles that are circulating in the blood. Your arteries are sort of marinating in these particles. And so even mildly or moderately elevated cholesterol, if for a sufficient number of years that they're exposed to this cholesterol, they still have earlier onset heart disease than patients that have had lifelong low LDL. So this is where lifestyle comes in. If we can just lower it, even a little bit through diet, the lower we can get is better. Now, we then assess, risk factors, because the more risk factors people have, the more intensive, we are about for prevention to try to, slow the train down. We want to, slow progression. So obviously the highest risk people are people who've already had an event. So if they've already had a heart attack or a stroke, they're already very far advanced. And so we are very aggressive with lipid lowering. In fact, we try to get the LDL, even under 55, as low as possible. There are other people, and this is particularly what comes up along a midlife, where women might have maybe their cholesterol's a little bit elevated, but not very elevated, or they have a family history, and we're really not sure about their risk. Then sometimes I'll do a test to see, do they already have plaque in their arteries or not? And one commonly used test is this coronary artery calcium score. So as that atherosclerosis, that plaque is building up in the arteries, it starts to get calcified over time. It starts to harden.
Yep.
It's probably not the calcium that's the risky part, but it just it starts to harden over time. So calcium shows up bright on X-ray, like white spots like bone or teeth. So calcium shows up bright. So you can do a CT of the heart with without any dye, with very low radiation, the same as a mammogram. So it's a very low radiation protocol. And see, do they have that white spots in the arteries that indicate calcium? And if there's calcium present, and particularly, the more higher the score, the more the calcium, that means that there's plaque already there. And so we treat that more aggressively because they already have disease. And so we want to prevent that disease from progressing. So when someone's risk is uncertain, I'll do some other tests to kind of help sort out the risk, like the coronary calcium. But if somebody's really low risk, we really then focus on lifestyle as the first therapy. And this is where trying to understand risk. And I think we're going to talk about some risk factors that women might not be even aware that they have that are female specific, but we do a tailored plan based on their own risk. And this is where I also check at least once that very genetically determined cholesterol called lipoprotein little a. I measure that once in a lifetime, because if that's high, that's another one of the factors that sways me that they're in a higher risk category. But there's lots of things that can put people in a higher risk category: family history, having a rheumatologic disorder like lupus or rheumatoid arthritis, or metabolic syndrome, kidney disease. There's other factors that also accelerate atherosclerosis, and where we want to be much more intensive about prevention. So it's all about risk assessment.
We're going to go back to the fact that how people actually find a doctor who knows how to do what you do and does it and takes, and is covered. But I wanted to turn now to the first line of treatment for high LDL, and that is a statin. And I wanted you to first explain what is a statin, why has it shown to be effective, so that people understand this medicine.
Yes. So as we talked about, cholesterol, particularly LDL cholesterol, is a major driver of risk. Statins work in the liver by preventing cholesterol, blocking cholesterol from being made. And so it's an inhibitor of the cholesterol synthesis. And that leads to upregulation of LDL receptors on the surface of the liver to clear all that LDL out of circulation. And in fact, we'll talk about some non-statin drugs, but most of them work by that same mechanism of increasing receptors on the liver to clear LDL out of circulation. So the first statin came out in 1987. So we have decades of experience with them, hundreds of thousands of patients, numerous clinical trials, and we see over and over and over again, all population groups, including women, that statins reduce the risk of major adverse cardiovascular events. So they reduce heart attacks, they reduce strokes, and they actually reduce mortality. So there is a survival advantage with treatment. And so they really are very safe class of medicines that have been so well studied. And they're safe and effective. So all of the guidelines list statins as the first line treatment for cholesterol lowering. And they've been out now. There's 6 of them that are generic, and some of the statins you can get for $5 at Walmart. So they're often very cost effective. So again, they're very safe and effective, but we'll talk about some other therapies. But the field has advanced now where we actually have non-statin therapies, quite a few options, both some more oral medicines as well as some injectable medicines that can also lower LDL. And they also seem to lower risk of heart attacks and strokes similarly, but there's nothing magical about statins themselves. It's all about LDL lowering. So if we can get the LDL lower through statins or combination therapy, a statin with a non-statin, or other, anything we can do to get the LDL down. And so we have more tools than we ever did before. But statins we have the most evidence for, so they're always the first thing we try when we know someone's at high enough risk that we have to, add a pharmacological therapy on top of lifestyle.
Yeah, so the issue of statins is also personal, because when I went to a doctor, and he basically recommended a statin based on my mid-level LDL, and my first reaction was, that's a man. Men take statins. Like, why would I, as like a middle-aged woman, like take a statin? And I don't know if that's the reaction of other women, and where I got that idea from. And so it took me a year or two more and listening more to different like podcasts and scientists to realize like this is like a good prevention strategy for someone my age. And I'm wondering, is that like, do a lot of women feel that way when they first hear that, or
Well,
or
there's
not?
still misconceptions. So statins are a treatment for cardiovascular disease, prevention of cardiovascular disease. And there's still this misconception that cardiovascular disease is a man's disease, even though it's the number one cause of death in women. And so the women are undertreated and not treated because they think, often falsely so, that they're not at risk. And like I said, we're seeing heart attacks. I just published a study last year showing heart attacks are on the rise, even in women under the age of 45, an age range where people don't even think they're at risk. Because unfortunately, we're less healthy. Young adults are becoming less healthy over time with the epidemics of obesity and diabetes. And so we're seeing heart disease at earlier ages. And so, yes, women are at risk. Not all women necessarily need a statin if they're truly low risk, but we, really need to assess risk a little bit better, because there's a false perception that women are somehow protected because they're a woman. And that's not the case. When I talked about that genetic condition, FH, familial hypercholesterolemia, there is no female advantage when cholesterol is that high. That women have the same early onset heart disease as their male counterparts. And we see from genetic studies that cholesterol is as much, if not more, risk factor in women as it is in men. So it's just as important in women. And the evidence, we have so many trials now, the evidence is very clear that women at risk benefit from statins as much as men do. So there's no interaction by sex. Women benefit just as much as men do. So we really need to treat appropriate patients regardless of their biological sex.
Yeah, someone just asked that very question, which you just answered, that they wanted to know, are statins as effective? Let me ask you one more question about this. We'll go on. I'm sure there'll be other questions about it. But if a woman says to you, if they're like moderate risk, and they say, "Give me a chance to try to lower my cholesterol through lifestyle changes," um, how long do you say they should take, and what do you say they should do? Or do you basically say it's unlikely you're going to be able to do that at this point through those lifestyle? How do you react to that question?
Well, it depends on how high their numbers are and how high their risks are. So this is where tests like that coronary calcium score, which is covered now by a lot more insurances because it's
Okay.
actually in the guidelines. In the guidelines that was, part of the American Heart Association guidelines, we gave a 2A recommendation, which is, should be considered in individuals where their risk is uncertain. You can do a coronary calcium score to help refine risk. And so it's in the guidelines, but if for some insurances don't cover it, which many do now, that's different than a decade ago. Many places it's only a $75 to $100 test, so it's not a super expensive test. But this is where I see if a patient already has a lot of plaque in their arteries, I consider them now high risk if their
Yes.
calcium score is
Okay.
high for their age and sex, because they already have disease. So we certainly focus on lifestyle, but they already have disease. I'll recommend pharmacological treatment. But if they're able to make changes with lifestyle, maybe we don't have to use, as high a dose.
Yes.
So if they already have plaque, I aim for an LDL less than 70, and we do a combination of lifestyle medications to get there. Now, if their calcium score is 0 and they have risk factors, but they don't have yet disease, certainly that does reclassify them to a lower risk category, where though it's not no risk. So we work on lifestyle. So I think it really is, needs a comprehensive risk assessment. But yes, if someone's LDL is already above 190, that's strong. That's very hard, get there up there with diet alone. That strongly suggests an underlying genetic,
Yeah.
problem, dyslipidemia, and medications are needed in that situation. But they work better with healthy lifestyle. So healthy lifestyle can help also bring the number down a little bit.
Can you talk a little about high blood pressure, and then we're going to turn to women, specific risk factors with women. You said to me before, there's some new thinking about where people should want their blood pressure to be. Can you explain that to everybody?
Yeah, well, this change was in the guidelines was back in 2017, but I find that patients aren't aware that they've changed the diagnosis of what's hypertension to be above 130 over 80. It used to be the threshold of hypertension was diagnosed above 140, the top number, and 90, the bottom number. But now we call hypertension above 130 and above 80. Where a normal pressure, is the top number is probably around 120, and sort of this 120 to 130 is elevated, but above 130 is hypertension. Certainly if somebody is otherwise low risk, and we treat everybody once they're above 140 over 90, again consistently, at least 3 occasions. We never act on a single read. But if someone's already a high risk, they have kidney disease or high risk for heart disease, we start treating with medications if they're been consistently above 130 over 80. So it's important to kind of know that new number, and we try to target with pharmacological therapy, keeping them under 130, the top number, and under 80, the bottom number.
Thank you. I wanted to go specifically to other risk factors specific to women, and if you can talk about a few of those.
Yeah. So, this is a show, but let's talk menopause. So, we know that early menopause is a risk factor for heart disease. So, we call it early if menopause is before the age of 45, and premature if it's before the age of 40. And it's a pretty linear relationship with, the earlier a woman goes through menopause, the increased risk of heart disease. Many women don't realize that vasomotor symptoms, when they're very excessive or prolonged, is also a marker of someone who's at higher risk for heart disease. So about 70 to 80% of women going through menopause have vasomotor symptoms. That's your hot flashes and
hot flashes and night sweats.
Night sweats, exactly. So that's very common. Most women experience that. But when it's very severe, when patients are having more than 6 or episodes a week, particularly if it's going on, more than 5 years. So most resolve within a couple of years, but extended, that's a marker. It may not be directly causing the heart disease, but it has been shown that that's a marker of a woman that's at increased risk for heart disease. So many women don't realize that's a risk marker. Other female-specific factors, we're really understanding the influence of adverse pregnancy outcomes like preeclampsia, gestational diabetes, having a preterm delivery. Not only does those factors increase the risk of having a heart complication at delivery, but the risk doesn't end at delivery. Those women who've had a complicated pregnancy can have risk decades after their index pregnancy. And that's why, as part of comprehensive risk assessment, we need to ask women about their reproductive and pregnancy history. In the setting of preeclampsia, they have a 4-fold increased risk of developing heart failure later in life, a 2-fold increased risk of a heart attack or stroke. So it's really important that we ask that history, because that might factor us being more intensive about prevention. Same thing with gestational diabetes. Those women are 10-fold more likely to go on to have type 2 diabetes, even if their glucose, their sugar improves after delivery. Sort of like pregnancy was like a failed stress test, so if they had diabetes during pregnancy, they're more likely to get diabetes later in life. So we follow them indefinitely, at least every year, screening with an A1C, making sure they don't have diabetes or prediabetes. So it's important that women have had that history, get a good cardiovascular risk assessment. Polycystic ovary syndrome, it's the most common endocrine abnormality of women of reproductive age. That's also associated with problems with blood pressure and lipids, and associated with increased cardiovascular risk. So these are all risk factors that women may not even be aware that they're related to their heart. And sometimes some doctors don't even ask women about these risk factors when they're doing a cardiovascular risk assessment.
Okay, so there are a number of questions here about menopause hormone therapy. And there are questions here about prevention. There are questions about if you have high cholesterol, then whether it helps. So can you give all of us an idea of how hormone therapy fits into this puzzle, both in terms of prevention and treatment?
So we don't use hormone therapy ever for the purpose of cardiovascular disease prevention or treatment of lipids. So we never use it for heart disease prevention because we have other things like statins that we can use for prevention. But that doesn't mean it's off the table. I think the pendulum swung so far that people are not using it at all. So there's still a role for the management of symptomatic vasomotor symptoms. As mentioned, 70 to 80% of women transitioning through menopause have these vasomotor symptoms, and they can be quite disabling for patients. The brain fog, the sleep disorders, this really affects quality of life. And I think we went too extreme with trying to avoid hormone therapy and too many women who are actually truly low risk. So really it comes down to a shared decision making between how symptomatic a woman is from their symptoms and what is their risk for heart disease. So we are, in the concern arose from the big trial, the Women's Health Initiative, where we didn't see a heart disease benefit and there was even concerns about risk. But it's very important to keep in mind in that trial that the average age of women was 63. So they were giving women hormones, very far out from their menopause transition. Many of the women were older and many of them weren't even having vasomotor symptoms at that time. So that's an important caveat of that trial. If you looked at the women who were closer to menopause, 50 to 55, we actually didn't see any excess risk in hormone therapy in that age group. So my approach is, we talk to patients. I work with our menopause clinic about, you do need to have some kind of cardiovascular risk assessment before starting. We generally still avoid systemic estrogens, either oral or the transdermal patch, in the highest risk women, the women who've had a heart attack, had a stroke, have had a blood clot in their legs or their lungs, what we call established cardiovascular disease. We generally still avoid estrogens in those. But women who have very low risk, they get a green light. If they don't have any of those major risk factors and they're symptomatic, as part of shared decision making, they might be a good candidate for menopausal therapy. And our usual adage is to use it for the lowest dose for the shortest amount of time. And usually we don't use it once a woman's more than 10 years out from menopause or over the age of 60 or 65. That gets into an age range where their heart disease risk may be high enough to wean them off by that age. Now, a lot of times what happens is some people have some risk factors for heart disease and there's some uncertainty about their risk. And so in my practice, I'll get that coronary calcium score. And if their score is 0 and they don't seem to have much plaque in their arteries, then that does put them into a lower risk category. We feel more comfortable with using that therapy. But very high risk women, we still then avoid the hormone therapy, but think about non-hormonal options for management. Now, keep in mind, I'm talking about systemic estrogens here. You can use, if a woman only has the genital urinary symptoms of menopause, vaginal or topical estrogens are safe even in women who have heart disease because they don't get systemically absorbed. So it's just really this discussion is around the systemic therapy. And among the systemic therapy, we think that transdermal estrogen through the patch may be safer than the oral estrogen from a pill because it avoids this metabolism through the liver. It gets directly, into the bloodstream. And of course, all women who have an intact uterus in place does need to take progestin for protection of their uterus.
So someone asked this question because you brought up the patch versus oral, and they referred to Dr. Blooming's book on estrogen, and they said not all estrogen has equal benefits on reducing heart disease. And so they said the oral showed up more benefit than the patch. And the question is, but the patch is not enough to protect from CVD or stroke. But are you saying there's not?
We don't use any hormone therapy for the purposes of heart disease. It is never used for that purpose. There is a purpose, in for controlling vasomotor symptoms. And if a woman had premature ovarian failure, they may take hormone therapy to the natural age of estrogen. but natural age of menopause. But we don't use hormone therapy ever for heart health. But that doesn't mean we have to avoid it. There's many women who are low risk for heart disease. So there, in terms of differences for risk, it depends on the type of estrogen, how it's administered, what age a woman goes through menopause, how long she's been out through menopause, her current age now. Like there's a lot of factors that go into this part of risk assessment. A lot of patients come to me and they want to take bioidentical estrogen, which is a marketing, nonsense. Keep in mind that estradiol, that's you can get in FDA approved products like your transdermal patch. Estradiol is bioidentical. It is identical. It is the type of estrogen that their ovaries made during their reproductive years. We'll never, in the trial that raised a concern about risk was that using the oral conjugated, equine conjugated estrogen. We will never have another large enough trial for outcomes with the patch, but there is some observational data suggesting that the transdermal patch may be safer in women who are at increased risk for cardiovascular disease than the oral. When you take a pill, it has to be metabolized through the liver, and so you can have this bump in your C-reactive protein and these other factors when it's metabolized by the liver. But when you do a transdermal patch, it avoids that first pass through the liver. But progestin is often taken through, you can take commonly what I use in my patients will be a transdermal estradiol patch with an oral progestin. But again, that's not for their heart health. What I'm assessing is cardiovascular safety. They're taking it for controlling their vasomotor symptoms.
Thank you. Someone asked about, so you said you do not take estrogen for prevention of
heart health.
Someone asked, has there been study to actually reduce the risk, reduce cardiovascular disease once a woman is taking it, though? Like, you don't take it to prevent it. Is there any data showing once you're on it, you have a better risk profile?
So we don't ever use it for the purposes of preventing or treating heart health. But, again, I was saying that doesn't mean it's off the table. There's still an important role. And a lot of women are low risk and would benefit from it. But we don't ever take it for heart disease prevention or treatment. But yes, some of my patients, once you're on estradiol, you want to make sure that their blood pressure is not elevated because that increases the risk of stroke. You certainly don't want to smoke and take estrogen. So estrogen is prothrombotic. It can increase the risk of blood clots. So not smoking, making sure your blood pressure is controlled. I make sure that their lipids are controlled. I kind of make sure that all their other risk factors are treated well so that any, potential risk of cardiac risk may be mitigated. But again, it does seem to be very safe in women who are around the menopause transition. And a lot of women are suffering in silence from menopausal symptoms. And I think the pendulum went too far from being afraid of cardiovascular risk to avoidance in a lot of women who might truly benefit. But we never use it for the purposes of heart health.
Thank you. So there are two related questions to hot flashes that I think are really important. One is, if hot flashes are under control with a medication, then does cardiovascular risk go down? Which is a great question.
It's a great question, and we don't know.
Let me just ask one more question, because someone else said, if you Veoza, that is a new non-hormonal drug to treat hot flashes, what do you think of that to treat severe hot flashes when a woman is over 50 and already has heart disease? So take the first one first about treating hot flashes.
So we don't know that treatment of vasomotor symptoms will reduce cardiovascular disease, because I don't know if that relationship is causal, like a direct cause and effect. So there are things that are associations where things are a marker of a higher risk person. And so it may identify a higher risk person, but it doesn't mean that treating that marker will lower the risk. So we know some things that women who have excessive and prolonged vasomotor symptoms, they may more often have an elevated body mass index. Maybe it's something about their sympathetic nervous system that makes them also more revved up and vulnerable to cardiovascular events. So it may be a marker of women who have other risk factors. And so, because we know in these studies, nicely done by Dr. Rebecca Thurston and others, that there's this associated risk, but that does not mean that treating the vasomotor symptoms will prevent cardiovascular disease. Now, certainly there's a lot of reasons to treat vasomotor symptoms, including improving quality of life, but that should not be thought that's necessarily a treatment for cardiovascular disease prevention. And these new therapies are interesting, but we don't have any data necessarily that they will prevent cardiovascular disease. But they may be options for women who are not candidates for hormone therapy due to other risks.
So someone asked here, and I think this is related to what you've already said, the impact of the lack of estradiol on cholesterol. So if your cholesterol increases after menopause, does having like an estrogen patch reduce your cholesterol?
Yes. So estradiol does, hormones are complicated. They do a lot of things. And so it's always this risk benefit ratio. But yes, we know that estradiol lowers LDL cholesterol and lowers LPA. So it can make lipids look better. But the reason why it's not recommended for lipid management as the primary treatment, because we have lots of other things, statins, non-statins, now we have lots of tools for lipid treatment, is that it has other, potential risks. So estradiol, can increase inflammatory markers. So C-reactive protein goes up. Estrogen is also prothrombotic. So this is why we see increased risk of blood clots, although maybe it's small, on oral contraceptives, even during pregnancy. Anytime estrogen can have a prothrombotic, it, increases some hormones related to thrombosis. And so this is why we think in older women over the age of 65, why it may be more harmful. They may be higher blood pressure, and it may be these adverse effects of being prothrombotic, cause more harm than the potential benefit on the arteries and the lipids. But in younger women, who don't have disease yet, hopefully, whose arteries are pretty clean, then maybe, it might have a benefit in lowering cholesterol and preventing atherosclerosis. But once there's already disease, those pro-inflammatory, pro-thrombotic effects, those risks may outweigh any benefit. So we don't use estradiol. It does make LDL go down, but we never use it for that purpose because we got statins, we got other things. So we don't use it for the purpose of lipid treatment.
So I have time just for two more questions. Obviously, people are so interested in this topic and have so many questions. I just wanted to ask a few quick ones. Can you take a statin if there's a history of Alzheimer's in the family?
Yeah, and actually, so there's no evidence that statins cause dementia or cognitive decline. That's been disproven. In fact, actually, statins seem to decrease the risk of dementia, mostly vascular dementia, because a lot of dementia is from non-Alzheimer's type, from mini strokes, and that people may not even aware that they have. So vascular disease leading to dementia. So statins may actually decrease the risk of dementia, and there may be some data that statins, may help decrease Alzheimer's risk, but that's not as conclusive of statins reducing vascular dementia. But I will say there's some new lipid-lowering therapies in trials right now, an agent, obicetrapib, which may have potential benefit on ApoE and brain health. So I'm really curious to see what happens with those trials, but stay tuned. There may be actually some cholesterol medications that may be even more effective at brain health. But I do want to keep in mind that the brain has this blood-brain barrier. And so your body cholesterol levels really have no bearing on your brain cholesterol levels. Your brain makes its own cholesterol. Your brain can synthesize cholesterol. So treating cholesterol in the bloodstream does not, change the cholesterol in the brain. And so I think patients somehow are afraid of treating cholesterol, but all the data shows, lower is better. And there's really no LDL that's too low, like lower is better, especially in high-risk patients.
So there are a lot of questions here about, we have to wrap up, but they're just questions about ApoB and what's a normal range. There's questions about non-statin therapies to use, calcium scoring. What source would you refer people to? Or if you could share with us, and we will send it out when we share the recording, of some basic information that our audience can review. I mean, is there anything off the top of your head, or will you provide something with?
There's lots of good things to the American Heart Association, the American Lipid Association. Hopefully most doctors are familiar, with the non-statin therapies. We got some oral therapies like ezetimibe, bempedoic acid. There's injectable medicines. So we have a lot more options around that. So those are all sort of good sources. There's a lot of information online about what a coronary artery calcium test is. And it's not for everybody, but for certain people where we don't understand their risk, for risk assessment.
Okay, I have to close up now. I just want to thank you so much. I mean, this was incredibly illuminating. I know for me, and I'm sure for all of our audience. So we just really want to thank you for being our panelists today. And that Let's Talk Menopause hopes we can continue to learn from you, and that our audience can also. So we just want to thank you for joining in, and you can drop off whenever you want now, Dr. Michos. We know how busy you are, so thank you. We appreciate your time. And for our participants, this is part of our monthly Menopause Talk series. Our next one is on bone health, and this is an equally essential topic that creeps up on people often. And many people, when they turn 60 or something, when they have their first scan for their bones, they find out they have osteoporosis. So we are going to share with you a way to sign up for our next menopause talk right now. It will be on May 22nd at 1 to 2 p.m. And we're also now going to release a survey, 3 short questions, so that you all can give us feedback and we can continue to improve our menopause talks for you. And thank you again, Dr. Michos, and thanks to you all. Please just fill out our survey quickly, which we're going to release in about 30 seconds. Thank you so much. Thank you.